First of all, I would like to thank Professor Liakopoulos for kind invitation to this Congress. And it is my pleasure to talk about a very interesting topic. I hope you will find it interesting. As we heard in a previous presentation, chronic heart failure, especially in patients with so-called cardiorenal syndrome or in patients with chronic kidney disease, is one of the common comorbidities, one of the common causes of morbidity and mortality in chronic kidney disease patients. But we know very well that chronic heart failure is a condition which is commonly present in many patients in the world, regardless of kidney function. And there is a question what we can do beyond the standard of therapy for chronic heart failure. And do we nephrologists have some tool to help the patients of chronic heart failure who doesn't have chronic kidney disease per se or is not complication of chronic kidney disease? So I will just briefly, this doesn't work. This one works, okay. Chronic heart failure, we all know that this is an important clinical syndrome which brings together cardiac symptoms and signs, which results in structural and functional abnormalities of the heart that cause increased intracardiac pressure and inappropriate stroke volume. This is the brief definition which is given by Heart Failure Association. And we know very well that the patients who suffer from chronic heart failure have multiple deterioration, amelioration, but generally it is a chronic progressive disease with very poor prognosis. The prognosis is even worse or maybe equal with those who has advanced cancer. So the prognosis of heart failure is very serious condition, and prognosis is very poor. The problem is probably within many comorbidities which are present in the patients with chronic heart failure. It is not only chronic kidney disease. Chronic kidney disease is just one part of it. As you can see, chronic kidney disease may be the cause, but also the consequence of chronic heart failure, which is very well described in cardiorenal syndrome. But we know that many other conditions are present in the patients with the heart failure. So this is a very serious condition, and we have a different class of drugs which are currently present. We learned from previous presentation extensively about the use of diuretics and with the use of some other drugs, but probably it is not enough, and the patients will need something more, and we as nephrologists will try to help in this condition. Okay, so we have three types of heart failure. Heart failure with restrictive or preserved left ventricular ejection fraction, or medium. This is new classification. We know also very well known New York Heart Association classification, which differs patients in the 4 stages of New York Heart Association stages. So as you can see here, we heard in the previous presentations about medical treatment of heart failure. There are different kinds of drugs: ACE inhibitors, AT2 blockers, beta blockers, MRIs, SGLT inhibitors, which are very promising according to results of novel studies, which can affect use of them may affect even the prognosis of heart failure. And there are also other agents which are commonly used. But there is probably life-saving therapy, disease-modifying drugs, because they can affect the natural course of heart failure, and in some patients to delay or avoid the worst outcome. We heard about diuretics in a previous presentation, but some patients are resistant to diuretics, and we heard the definition in previous presentation, what is the resistance of, in the use of diuretics. If this treatment fails, we need to do something more. We as nephrologists are very familiar with different methods of renal replacement therapy, which includes different types of dialysis, especially hemodialysis, not only intermittent but also continuous, different types of hemofiltration, but also different types of the use of peritoneal dialysis or peritoneal ultrafiltration. So this is my topic today, and I will explain to you how peritoneal ultrafiltration could affect the outcome of chronic heart failure, regardless of the presence of the chronic kidney disease. This is also recognized by the guidelines. The guidelines of European Society of Cardiology has said that renal replacement therapy should be considered in patients with refractory volume overload and end-stage renal failure. As you can see, the guidelines are referring to the patients with chronic kidney disease, but do not refer to the patients without chronic kidney disease and refractory resistance diuretic heart failure. So what can renal replacement therapy actually do? It is good to have minimal impact of hemodynamics, because we know very well that those patients are very prone to hypotension and also different neurohumoral stimulations, so it could be problematic. But we can do continuous removal of fluid of volume load or fluid and also electrolytes. We can stabilize the patients to better respond to the conventional therapy. Also, in some cases, drainage of ascites and the reduction of intra-abdominal pressure may relieve some symptoms of the heart failure, especially right one. Of course, it could affect to the quality of life. I will show you at the end our experience with those patients. So peritoneal ultrafiltration, it appears to be a promising therapy to support the patients with chronic heart failure, which are currently refractory to diuretics, and with or without, even without chronic kidney disease. What can be beneficial effect of peritoneal ultrafiltration? It can improve the congestive symptoms. It may decrease the number of hospitalizations and duration of hospitalizations, so the patient will be less in the hospital. It will definitely ameliorate the quality of life of the patient. It will, at the end, decline the cost of total care, and the patient will be better in exercise, and this is also the part of the quality of life. But also it can be used as a palliative therapy, as a bridge to transplantation, to the heart transplantation, because there are some patients, while waiting for the heart transplant, may suffer from different conditions, and predominantly most of them suffer from the increased intravascular volume, which can be done with the peritoneal dialysis. The choice of technique depends on renal function. What can we do? If we have a patient with a conventional classic cardiorenal syndrome with advanced chronic kidney disease, obviously we can use so-called conventional peritoneal dialysis with the use of different solutions. But if we have a patient without chronic kidney disease, then we actually do not need to remove those uremic compounds which are not present in such patients, but we need to remove only volume, fluid overload. So we can use only ultrafiltration with the use of specific solutions which can cause better ultrafiltration than those which are currently used in CAPD or APD. We can use it by means of conventional PD as ambulatory, or even better, if possible, with automated peritoneal dialysis with the machines. So we can use within the hospital, within the daily hospital, or even at the home of the patient. So what is prescribed, what the prescription of such ultrafiltration will consist of? We will use a polymer of glucose, icodextrin, in these situations, which is a high osmotic agent, and can cause significant ultrafiltration of the patient by means of transport through the peritoneal semi-permeable membrane. We already know what is the composition of the membrane and how the water passes through the membrane. This is the classic 3-pore model, which we are already familiar with. So the use of large, small pores and aquaporins, which are transporters for the water, and the result is net ultrafiltration, which we already know in the patients with a PD. So use of oncotic and osmotic pressure on the side of in the solution, but also net ultrafiltration is not only because of osmotic pressure. Some ultrafiltration, but back could be because of hydrostatic pressure, because of concentration of the albumin in the patient, because of intraperitoneal pressure. Solution makes intraperitoneal pressure, and also some lymphatic reabsorption. But generally, the net ultrafiltration is usually in a part depends on osmotic agent, and this is why we use, in these cases, we use polymers of glucose such as icodextrin. I show you the role of aquaporins. So what is the role of the solution? I just described that we need the balance of the internal environment by balance of the electrolytes. In patients, if they're acidotic, if they have a chronic kidney disease, we need to correct acidosis. If the patient has chronic kidney disease, then we need to remove all waste products. But especially in patients without chronic kidney disease, we need to extract water by osmotic agent. Glucose and amino acids are not so powerful, but icodextrin is. Icodextrin is a solution which is very powerful for ultrafiltration in these patients. So, as you can see, local PD prescribing. You can see the two graphs before and after introduction of APD with icodextrin. And you can see that there is a difference in patient survival in peritoneal dialysis. We know that before, peritoneal dialysis was considered as less effective, but now using the modern solution, peritoneal dialysis is at least equal effective as hemodialysis, in some patients even better. Okay, so here you can see the comparison of net ultrafiltration during PD dwell. So if we have a long dwell, then we will have a sustained ultrafiltration. And as you can see, the curve for icodextrin. And other two curves are for glucose in different concentrations. So when we have a night dwell, during a PD dwell, there is a very well and sustained long dwell. If we compare glucose in highest concentration, which is currently in use, and icodextrin, there is a big difference between them in favor of icodextrin for removal of the fluid. Also, you can see on these graphs differences between icodextrin and 2.27 glucose. So what are generally advantages of icodextrin? Icodextrin may be associated with improved patient survival, as we can saw. The use of the icodextrin solution has been associated with a lower risk of new onset chronic heart failure in PD patients. So in this case, we have a consequence of chronic kidney disease, which when we compare with the patients who are not using icodextrin solution, it may be associated with improved profile in some lipids, even in PD patients. It helps also in preservation of peritoneal membrane. We know that if we longer use peritoneal dialysis, then we could have a damage of peritoneal membrane and insufficient efficacy. And also, in that case, we avoid the glucose, so this can be additional benefit for this peritoneal membrane. We have several studies which were observed use of peritoneal dialysis in advanced heart failure. I will show you just briefly those which are important. So when we compared dose of diuretics after use of peritoneal dialysis, very big difference, clinically significant. So the dose of diuretics is diminished after use of peritoneal dialysis. There is also increase in hemoglobin levels. Then also left ventricular diameter. There is a significant improvement in left ventricular diameters and significant improvement of NIHA class of the patients. They usually start with the NIHA class 4 or 3, but as you can see, after the treatment, NIHA class is better. So the same was showed in a meta-analysis. In this meta-analysis of 31 non-randomized studies in a large period of time. As you can see, patients were treated with a PD. They have fewer symptoms, a lower rate of rehospitalization, and shorter duration of hospitalization compared with those which are treated only with diuretics. Ultrafiltration and especially PD represent potential useful therapy for the patients who have severe chronic heart failure, if they have resistant symptoms and they have frequent hospitalization. So probably this is the way we should go with our patient. And I will now show you experience of 3 musketeers. I will show you the experience of one, because we don't have a lot of time. So our multidisciplinary team in our clinical hospital in Rijeka in Croatia consists of those specialists, cardiologists, nephrologists, urologists, anesthesiologists, and PD nurse. This is essential for the therapy because these therapies cannot be done very well if you don't have a specific and dedicated team for the treatment of such patients. So this is our patient, 71 years old, NIHA class 4. As you can see, he's very sick. He has multiple interventions of the heart, and his heart failure is in definite stage. And as you can see from the course of his treatment or his condition, always he had anasarca and dyspnea, and obviously this is the patient whose prognosis is actually very, very poor if we do not intervene. So, 3 years ago, he was refractory to diuretics, and then we inserted peritoneal catheter in February 2020. And then we started with intermittent ultrafiltration 3 times per week. And then we had some surgical reposition, and then we started with education for the patient. And the patient has fully mastered his skill and independently performed peritoneal dialysis. Remember that he is not a chronic kidney disease patient, he's a chronic heart failure patient. We started then with icodextrin intraperitoneally, 12 hours night dwell. We removed central venous catheter because it was not necessary anymore. And as you can see, as a result, his loss of the weight was 22 kilos from the baseline. Probably all of this was the water. And this is his results in NT-proBNP, albumin levels. CKD was not changed probably in this period, so his GFR was pretty much stable. His diuresis was very well. And this is the ultrafiltration which is used with peritoneal dialysis. So as you can see, he started with more or less 100 kilos, and he lost 20 kilos, and now is in IHA 2 class, not 4 anymore. So cardiology examination, the patient feels good. Since being treated with peritoneal ultrafiltration, there are no symptoms of heart failure anymore, and no edema present. So we can treat these patients in very advanced chronic heart failure with the use of nephrology tools. So peritoneal dialysis is our tool, and as you can see, we can help even the patients with a heart failure. We have 2 more patients, but I don't have time to present them. They are pretty much similar, and after that, there are very fewer cardiology exams and visits. They feel well. One of them even drives bicycles. So before that, it was impossible. Thank you very much for that.